This is Anesthesia 2020 CPT. This video will go through the anesthesia section as an overview, go over notes that you may need or want to have in your CPT, and then we'll do some specific application of codes. That will all be in this one video. There won't be a separate video. So first of all, I have notes regarding anesthesia. It keeps me from having to go to the HCPCS to find these modifiers. And these modifiers, to some extent, kind of help you understand the use of this section. So this particular section, anesthesia, unlike the other sections in the CPT, is only used for the administration of anesthesia by an anesthesiologist or a nurse anesthetist, okay, by the doctor who is administering the anesthesia. Keep it that way. So all of this book is about surgery. Most of these surgeries will have some type of anesthesia, probably more than a local. These sections are the surgery sections, so you're coding for the surgery, the action going on, and not the anesthesia going on. This section is for the anesthesiologist who was in all of these surgeries, but this is for his time in administering the anesthesia. So that's kind of the difference. All of these codes will start with a 0. That's how right off the bat you know that it's a anesthesia code. Modifiers that I list and kind of keep at a really quick reference. Your AA modifier, that's for the anesthesia, is being administered by the anesthesiologist, the MD. AD is the medical supervision of the anesthesiologist overlooking greater than 4 concurrent cases. So that means the anesthesiologist, the MD, is concurrently at the same time looking over greater than 4 surgery procedures. He's supervising. G8 is a MAC, monitored anesthesia, MAC, and that's a complex level. G9, MAC, severe cardiopulmonary. You see a GC, that means there's been a resident involved. It's with a resident. Now your CRNA, Certified Registered Nurse Anesthetist, would have a QK, that's medical direction. So she or he is being directed by the anesthesiologist to 3 or 4 concurrent cases. QS is MAC, monitored anesthesia, not complicated. So QS and G8 and G9 all go together, just depends on the severity. So if you don't have any documentation that it's complex or cardiopulmonary, then your QS is your MAC, uncomplicated. QY goes to the CRNA for medical direction. They are being directed. So it's one-on-one. A anesthesiologist is directing the nurse anesthetist, only 1 case. QZ, there's no medical direction. The CRNA is performing the anesthesia without any direction. QX, direction by a physician, but they're not an anesthesiologist. So this could be potentially maybe a plastic surgery that's being done in the office or in an ambulatory surgical setting. The physician, the plastic surgeon, is having their nurse anesthetist or even an RN, I've seen this, not smart, but I've seen it, take care of the anesthesia under the direction of just an MD, not an anesthesiologist. Also, all of the P modifiers, but I don't list them here because they are listed over here, and we'll go over that in just a second. The formula that you may need to know, you'll probably have one question on your board about it, is B, which is base, plus T, which is time, plus modifying factors, times the conversion factor. And we're going to go over that in a little bit. I've got an example on a index card that we're going to go over how to apply this. Something else to know, your local anesthesia, anytime, anywhere, is always bundled in. You're not ever going to code additional for a local anesthesia. Common modifiers from this cheat section. Remember, this is our cheat. Common anesthesia modifiers would be 47. This is anesthesia by the surgeon. So this goes back to this QX. 59 modifier, if anesthesia provides, or if anesthesiologist provides a separate and distinct procedure on top of the administration of the anesthesia, then you would code this in addition. So you would use a 59. Let's say the anesthesiologist was responsible for the anesthesia on a surgery on the arm. And so what they do, high up on the arm, they do a regional, they do a nerve block. And or some type of, maybe you're getting a conscious sedation and then you get a nerve block too. So at the end of the surgery, the anesthesiologist might give another nerve block or a different kind of nerve block for maybe 6 hours of pain relief or something like that. That would be over and above the anesthesia for the procedure, so you would put a 59 modifier on it. And then also unusual anesthesia, which is modifier 23. So I just I rewrite these here. Once you get familiar with stuff, you probably don't need this. This is just good for me. I'm not in anesthesia a whole lot, so I can come to this page and it just jogs my memory. It's clear, it's concise, it's written neatly. Any notes you put in here are not going to be flagged on a book check for your board, so you should be good to go. Okay, moving on. Here is your index. You can use it or not. Here's your green pages. Remember, green pages are guidelines. Does give good information about time reporting, when time starts for anesthesia, supplied materials. This is just a really good, concise synopsis of some of the key diagnoses. Key guidelines. Sorry, I got diagnosis on the brain because of HCCs. Special report. We haven't talked about that yet. You generally have to always, well, we talked briefly about it. Anything that is a procedure on the unusual side or an unlisted procedure always has to be accompanied by a special report from that physician. Now, your anesthesia modifiers. These are specific to every this is specific to your physical status of the patient. These physical status modifiers will go on every single anesthesia code. Every time. You have to have a physical status of your patient. So you have a P1, that's a normal healthy patient going into surgery. They are normal healthy. Maybe they have a ganglion cyst. Maybe they are having open heart surgery, but they have, they were healthy before they went into surgery. Probably not that. That's probably not a good example. But they were healthy going in. 2, patient with mild systemic disease. This would be, yes, they have a systemic disease, but it's controlled. It's not causing them any trouble, or it's on a very mild level. P3, a patient with severe systemic disease. So they do have systemic disease and it causes them trouble or is severe in nature. P4, patient with severe systemic disease that disease is a constant threat to life. P4, moribund patient who is not expected to survive without the operation. So that means mortality is very near for that patient, and if they don't get the surgery, they will die. That would be that scenario. P6, a declared brain dead patient whose organs are being removed for donor purposes. So that's self-explanatory. In the real world, your anesthesiologist most likely will be assigning these, but for the purpose of understanding them, you will have to have them assigned on the CPC board. So let's do a few examples, and I've kind of written these out so maybe you can see them. So a healthy patient undergoes a colonoscopy. They're going into that procedure completely healthy. Maybe it could be diagnostic colonoscopy. It could even be most colonoscopies are decided to be diagnostic. But what I'm saying is the patient could be completely benign. They have zero symptoms, and so they just do this every 10 years. Or that patient maybe now is having chronic diarrhea or something like that. Nothing's been diagnosed on that patient yet. It's still a diagnostic colonoscopy. That they may end up doing something. Maybe they have something going on, diverticulitis or something going on. But going into the colonoscopy, there are no pre-existing diagnoses that makes this not a healthy patient. So that's a P1 physical modifier. A patient with ESRD, that is end-stage renal disease, undergoes a laparoscopic cholecystectomy. So ERD, end-stage renal disease, this would be a P4, patient with severe systemic disease, that would be end-stage renal disease, that is a constant threat to life. And ESRD would very much be a constant threat to life. Most likely they're on dialysis, and without the dialysis, they're probably very likely not going to live long. So that would be a P4. Let's do two more. Patient with late-stage breast cancer undergoes mastectomy. So late stage, it's been diagnosed. We know this patient is sick. They're going under and getting a mastectomy, removal of that cancer. That is a P3, patient with a severe systemic disease. So late-stage breast cancer, this is not just a lumpectomy that they're doing. That might be a stage 1, stage 2, could even be a stage 3 if it's just a lump, but they're removing the whole breast here. So that would be a P3, severe systemic, an example of that. Here's an example of P5, patient with cardiomyopathy having a heart transplant. So P5 says a very, very sick patient who is not expected to survive without the operation. If you are getting a transplant, pretty much of any kind, that is probably a life-saving event. So that would be a P5. So there's some examples of how you would use these physical status modifiers. Again, they are on every anesthesia code. So if you are on your CPC board and you have a choice, you'll have 4, it's multiple choice, you'll have 4 suggested potential answers. If any of those anesthesia codes don't have a physical status modifier, you can kick that out of the running because it would not be accurate. Now, qualifying circumstances. These are add-on codes. You see they have a plus. So these would piggyback on the O codes from your anesthesia. Your 99100 is anesthesia. You would piggyback this on, and it would be anesthesia for any patient with extreme age. So they're younger than 1 year and they're older than 70. I will tell you, and it gives you a parentheses right here. And parentheses are vitally important in your CPT. Always, always, always read them. It's telling you you're not going to put 99100 on an anesthesia code. That code is for a baby or for a infant under the age of 1. That would be redundant. You don't use it. They will do that on the board and have you use stuff like that. So know this guideline. 99116, anesthesia complicated by utilization of total body hypothermia. That's when you have to bring the body down to a low temperature. That's several kinds of surgeries. Very much heart cardiopulmonary surgeries. 99135, anesthesia complicated by utilization of controlled hypotension. So if they're controlling and keeping the blood pressure low, that would be how you would use that. 99140, this is anesthesia complicated by emergency conditions. So if a patient comes in and they have to go straight to surgery or something, you don't know the condition of that patient coming in. They're coming through the emergency room. Remember, everybody's new in the emergency room. So if you delayed the surgery to get that information, it could be a huge threat to the patient. So this would be piggybacked on the anesthesia code to signify that this was done in emergency conditions. And that would flag and say, we just don't have all the information. So that's why it was emergent. We had to do it because the patient was life-threatening, had a life-threatening condition. Okay, so moving into the actual anesthesia codes. I put a note up here for me, only used when coding for the anesthesia service, not the surgery or the procedure, but the anesthesia on the surgery. Like I do several times, I do keep notes in, helping me remember what words may mean, so I don't have to look it up again. If it's in an area that I don't routinely use, it's just better for me to have a note in. So for me, a tympanotomy, this is code 00126, is also a myringotomy. That just helps me. Some docs document it either way. That just lets me know that I'm at the right place. The anesthesia section starts at the top of the body. So here's the head. So anything happening to the head, this is where you would find the code. These anesthesia codes are very generic, very general. They do complete body areas or body parts all in one. They don't break it out too much, which makes this an easier section to code from. The rest of the CPT is extremely detailed. So we have neck, we have thorax, so this is the chest wall and the shoulder. We have intrathoracic, so that's inside the chest. We have spine and spinal cord, upper abdomen, lower abdomen, perineum. Then we get into little bony stuff. So we have a pelvis, your upper leg, knee, popliteal, that's behind the knee. We have lower leg, shoulder, axilla. So it jumps around a little bit when you get to your arms and legs. But once you're in the lower body, it flows. Once you're in the upper body, it flows. Oops. No. We have specific radiological types of procedures, arteriograms, venographies, that kind of stuff, interventional radiology stuff. We have our obstetrical stuff in here, your epidurals, that kind of thing. And then pretty much anytime you have other procedures or a section titled introduction, those are a little bit of a catch-all. So you usually really have to read those particular areas. What is probably most heavily used in the other procedures here is your daily hospital management of the epidural. So if someone had an epidural and has to have it into the next day, this would probably be used by the anesthesiologist, as they would still be monitoring the effectiveness, the patency, and the integrity of that epidural. Okay, so that's anesthesia. There's not a heck of a lot of codes. So let's do a little bit of drilling and kind of playing around with some of these. And then we're going to get to an example of using the relative value and how you determine the payment for the anesthesia. I will say the 321 coded book, you should be in chapter 11 in it. It is an excellent synopsis of so many things that fill in the gaps. What types of anesthesia are there? What's included in what's included in anesthesia, like pulse ox and that kind of stuff. It's really, really an excellent synopsis of all the different components that go into anesthesia. So I very, very, very much, and every section in the 321 coded book, every section within anesthesia has an example that you can read to see how it's practically applied. We're just going to do a few of them. So starting on the first page. Here's the example. An anesthesiologist provides anesthesia to a terminally ill 1-year-old patient who underwent a laryngoscopy. So the anesthesiologist did the service. So we know we have to append modifiers for the anesthesiologist. So he did it or she did it theirself. So that's an AA. So we know that's a good modifier. We have a terminally ill baby, but they're 1 year old. So terminally ill would be a P4. They have a severe systemic disease that's a constant threat to life. They are 1 year, so we would not append the 99100 because that's younger than a year. So now let's find our actual code. So this is for a laryngoscopy. That's going to be, your larynx is in your neck with your pharynx. So that's going to be under the neck. So always find your body part. So our body part's the neck. We want a laryngoscopy. So this is an endoscopic procedure. So here we have anesthesia. What's the difference? I have to sit and look. So I'm looking at the difference between 00320 and 00326. Both of them are anesthesia, which includes the larynx. So the difference, and this is exactly how I would do it in real life. The difference is 00320 is age 1 or older. 00326 is children younger than 1. So because this patient is 1 year old, then I'm going to choose 00320. That's going to be my code. You see how that's just a real generic code, just all inclusive. So how this would be documented is 00320-AA, that's for the anesthesiologist administered, -P4. How do you stack your modifiers? I always, if I have a modifier, any way, shape, or form that affects the money, I stack it first, and then I do my informational. And you can stack 3 and 4 and more modifiers deep. So the AA tells me who the money goes to. That's the anesthesiologist, so that affects money. That's reimbursement. I do it first, and then my physical status modifier, P4. Of note, code 00326 is a code that includes, it's geared only toward kids under 1 year of age. So because, remember the, this little parentheses here, it says don't apply the 99100 to codes that are already geared toward that age group. So this is one of those examples. You would not use the 99100 with this code because it's already all inclusive and only for kids under a year of age. Okay, so let's do another one. Let's do from the interthoracic area. So this is the area we're going to go to. 39-year-old patient with severe systemic disease. So they're giving you that P status. Severe systemic disease, underwent sternal debridement for which the anesthesiologist provided general anesthesia. So again, we're going to have our AA, anesthesiologist administered. We have severe systemic disease, so that's a P3. So now let's find our actual code. So this, our body part, they went under a sternal debridement. Sternal, sternum, that's within the chest. It's not a chest wall, it's the actual bone that kind of is what your ribs are attached to on the front side of your body. So now we're going to look for the sternum body part. So I'm just reading. So here we go. Anesthesia for sternal debridement, 00550. So how you would apply that, or how that would write out, is 00550-AA, because that's the money modifier, dash P3. Good job. Okay, let's move on and do an example. Let's do the lower abdomen. Let's do that example. Anesthesiologist provided regional anesthesia services to a diabetic patient who underwent total cystectomy. Total cystectomy. Okay, so what do we know? Regional anesthesia services to a diabetic who underwent total cystectomy. The anesthesiologist provided is what they told us. So again, this is an AA, anesthesiologist provided. They do have diabetes, but we have no documentation that it's severe, that it's a constant threat. We do not have any of that. So I would give them a P2 based on this documentation. They just are diabetic. We know no other severity. You can't assume anything. You can't give them healthy because they have something on board. But all we know about it is that it's present. So I'm going to assume that it's a mild systemic disease. So it's a P2. So now we need to find a total cystectomy. So what is a cystectomy? This is lower abdomen. Cysto, meaning bladder. Ectomy, meaning removal. So I gotta just kind of look. So anesthesia for extra peritoneal procedures in lower abdomen, including urinary tract. Well, we know cystectomy, cysto meaning bladder. So then let's look down underneath here. Code 00864, total cystectomy. And they told us it was a total. So here we go. So this is how you would write out this code. 00864-AA-P2. Okay, let's do a shoulder. Let's just keep kind of moving through here. Let's get to our shoulder and let's do it. Anesthesiologist provided general anesthesia services to a normal, healthy patient who underwent muscle biopsy of the left shoulder. So anesthesiologist administered, so that's an AA. Normal, healthy, that's a P1. So I'm not going to go to those because we're already getting familiar. So now I'm just going to find that particular procedure on that body part. So the actual procedure underwent muscle biopsy of the left shoulder. So I found my body part Now I've got to find something to do with the muscle. Anesthesiologist for all procedures on nerves, muscles of the shoulder and axilla. Let me just make sure. So this is arthroscopic. I can't do that. This is arteries. I can't do that. Veins. I can't do that. And a cast. So 01610 is what I go with. Now we know that it's the left shoulder, but this code has so much bundled into it, we would not do 01610 LT. The actual surgeon may be putting that on the left shoulder because there's a mirror image of shoulders, but you would not do that on anesthesia. So the whole code here would be 01610-AA-P1. Okay, let's do one more, and then we're going to talk about the reimbursement or the relative value and how you come up to the reimbursement of the anesthesiologist. So let's do a burn. There aren't a lot of codes here, but there's a whole lot packed in the codes, and I want to have an example of how we would apply that. Okay, so the anesthesiologist provided general anesthesia to a 2-year-old type 1 diabetic patient who underwent second-degree burns of the chest, 5% total weight. So that's a lot of information. So first, it's anesthesiologist administered. So that's an AA. The patient is a type 1 diabetic, but that's all we know about. So we're back to the P2 because diabetes is systemic, but we have no other criteria to make it anything but mild. So we stick with the P2. And then now we've got a burn. So we got to our burn. Second degree chest, 5% of body surface. So let's see in here what code we need. So here's anesthesia for second or third degree. So second, we know we're right. With or without skin grafting, we don't have that. Total body surface treated, less than 4%. And then 01952 is between 4 and 9%. Now remember, your indented codes, we take the description above to the semicolon, and then we hop down to the indented code. So all of the description, anesthesia for second and third degree, burn excision or debridement with or without skin grafting, any site, so our chest fits in there, for total body surface area treated during anesthesia and surgery, semicolon. That's that whole description. Then we'll piggyback on our between 4% and 9% of total body surface. And we know we have 5%. So we would have code 01952-AA-P2. All right, the last thing with anesthesia, let's go back to this formula. The book does an excellent job of giving multiple examples of this. I'm just going to give one example. So you have base units. That's what the B stands for. So base units, if you were actually coding for anesthesia, you would have a manual, a book, a software program, something that would give you the base unit for every code in anesthesia. So every O code has a base unit assigned to it. You don't come up with that. So you get whatever that assignment, that base unit is. Time, you have to always, anesthesia is based on time. Every 15 minutes is 1 unit. Usually that's what it is. You would need to check that, but generally that's what it is. So there would be 4 units of time in an hour, because there's 4 15 minutes in an hour. Your modifying factors, that's if you used any qualifying circumstances, your physical status modifiers. I think P3 and up have a value. P1 and P2 do not have any kind of value. times a conversion factor. And I even wrote that wrong. Look at that. I do that. My mind goes before my brain does. Conversion factor, that is your location factor. So someone who is practicing in New York is probably going to have a higher conversion factor because the cost of living is higher there than someone living in Oklahoma, something like that. So again, that conversion factor is given to you. So all you do with this formula is just plug the information in. So I, again, have written something out, and let's just talk through it. There's a lot of information on this page. I know that, but we'll work through it. So we have a 22-year-old with chronic asthma having a vaginal delivery. So the anesthesia that was administered is a neuraxal. It was neuraxal anesthesia. That is code 01967. Her chronic asthma is a P2. Remember, we don't have anything else than that. We have to acknowledge that they have a disease process, but if the doc isn't going to tell us it's uncontrolled or something, then we can't make it something that isn't. So the patient was under anesthesia for 45 minutes or had anesthesia for 45 minutes. There was no modifying unit. That means she wasn't a P3 or above. There's no qualifying circumstances, nothing unusual. And they live in New York. This is being done in New York. So now let's do our base units. So for this code 01967, the base unit is 5. I got that from whatever manual that I'm working in. The book actually gives it to you for these examples. So that's our B, is a 5. Anesthesia for 45 minutes. Every 15 minutes is 1 unit. That's your time. That would be 3. There's no modifying, so that's nothing. And then your conversion factor for New York is 17.45. So now let's turn this over, and this is how the equation would be. 5 is your base units, and do you see how I'm just following right here? So 5 is your base units, plus 3 is your time units, plus 0 modifying, that comes to 8. And then you times that, multiply it by that conversion factor. So you take your base time modifying, add it together, which is 8, times it by your conversion factor, and it comes to 139.60. So for that 45 minutes that the anesthesiologist had the neuraxal anesthesia, his reimbursement is $139, or the billing is $139.60. And that's how you would use that. I do not believe on the CPC board you'll have to do any actual figuring. What you may have to do is accurately tell what this equation is. So you're going to need to know base plus time plus modifying times conversion. That's why I have it written in here. So this is anesthesia in a nutshell. We've gone over several examples. Pretty straightforward. Your 321 coded book is excellent with lots and lots and lots of examples on how to apply this stuff or these codes. So see you on the next video.